services for older adults. Dr. Zechner's research includes the development of multi-domain wellness programs for people with serious mental illnesses, promotion of and adherence to physical activity in people with SMI, use of peer health coaching strategies, and identifying best practices for use with older adults with mental illnesses. She's well published and presents on these topics nationally and internationally, and we are very happy to have her here with us today. Dr. Zechner?
Hello, everyone. Welcome. Welcome to downtown beautiful Scotch Plains, New Jersey, where we are learning how to advance the slides. Sorry about that. Okay, so welcome, and this is what we're hoping to achieve today, to be a little more familiar with older adults with serious mental illness, talk about the growing population, talk about the specific health concerns that people experience and their psychiatric symptoms, and also to evaluate the strengths that develop with older age. I'm very excited to be presenting this information to you today because one of my first jobs that I began working in a nursing home in the early 90s that had mostly a population of people who had been deinstitutionalized from the state hospital. So this is one of the first presentations population that I saw, and I continue to think about and wonder how we can support and help this group. There's an incredible gap in knowledge about the population, and it's not very well studied or understood as of this point. So let's hear from you. I wanted to kind of get a sense of who's in the room a little bit, or more or less what you know. At what age do you consider someone an older adult? So if you could just go ahead and there's a poll that should be popping up on your screen, and answer the poll, how would you define an older adult? This is pretty interesting because I'm seeing live what the numbers are. And so far, it's sort of like the horse races. So far, we've got people saying 60 is the number, but I want to wait a few more seconds to see what other people are thinking. Okay, so a lot of people, I would say most, are saying that 60 is sort of the older adulthood age cutoff. And that's about 54% of the people who responded, 26% 70, and 15% 50. Well, the interesting thing is that we're going to be talking about people with a mental illness, and the challenge is that people with serious mental illness have experienced premature mortality. So on average, people lose life between 12 and 30 years who live with a serious mental illness. So if you say 60, I would say from gerontology, we would say 65 and above is young adulthood, young older adulthood, 75 and over is mid older adulthood, and 85 and older is old or oldest old. And 55 would be emerging old. So let's go with the next poll question. What conditions are considered a mental illness? So we'll show a poll shortly here. And if you could just indicate which of the following you think are a mental illness. And it looks like a lot of people are identifying schizophrenia and bipolar disorder. Okay, we'll give you a few more seconds to finish that poll. Okay. So almost everyone, 99%, said schizophrenia and bipolar disorder, 91% said depression, and 81% said anxiety. And I would absolutely agree that delirium and dementia are also mental illnesses. However, I want to clarify that for this webinar, what I'll be talking about is people with serious mental illness, primarily schizophrenia, depression, bipolar disorder, and generalized anxiety disorder, or anyone who basically is served by the public mental health system. So we're talking about older adults, and unfortunately I just did a literature review where hoping to have published soon, where we had to identify older adulthood as 45 and up, which was pretty shocking. But we needed to do that because of the premature death rates, and also that's what a lot of the interventions are addressing, older adulthood as 45 and over. So I encourage, as we go through this, to be thinking about the accelerated aging of older adults with serious mental illness, their physical and their cognitive aging. So now that we're sort of on the same page with our language and definitions, let's talk about some of the differences in the diagnosis in age onset versus non-age onset. Older age onset of illness is typically diagnosed later in life, so it isn't something that someone has throughout their life, and it's often anxiety, depression, delirium, or dementia. Psychiatric illness is not related to age, or as I often refer to them as serious mental illness or severe mental illness. When we think about that, when is a mental health diagnosis like that typically made? And those are typically made between 18 and 30 years old. And what illnesses are typically included are the ones we just referred: schizophrenia, bipolar disorder, major depression, etc. There are some unique issues for older adults with serious mental illness. There are complex health issues and medications. We're going to go over this issue a lot, of the health issues. They also are at risk for falls related to medications. There's often people have gait problems or walking problems. They may be taking medications that are sedating, and they may be more sedentary, so they have more physical risks for falling. So we need to be really aware of that. Also, this population can be fairly vulnerable, particularly to financial exploitation. So elder abuse is pretty common. And also stigma. When we talk about ageism, we're talking about sort of a clinical pessimism that older adults can improve or make changes to their lives. And I've seen that in mental health providers, but also I've seen it in older adults with mental illness themselves having self-stigma, not believing that they could get better because of their age. There are few dedicated resources. We don't see a lot of resources. When we talk next week about programming, I'll give you what we know, but there's not a lot out there. And that also, there's a challenge with the workforce in that, I've worked in mental health systems and I've worked in aging systems. Mental health doesn't know a lot about aging, and aging tends not to know a lot about people with serious mental illness. So there aren't a lot of people who can sort of speak that language or are comfortable in both realms. So we need to do a little more workforce development, and the Institute of Medicine had a great report called In Whose Hands, that's in the reference section, that addresses this topic very comprehensively, and it's still an issue 7 years later. There's also the issue of trans-institutionalization, which is that for older adults who are living with mental illness, they may be experiencing frequent hospitalizations, and they may move directly from the psychiatric hospital to a nursing home. So they sort of have that impact of institutionalizations that they carry over, which is a whole other subset of issues and problems. So older people with mental illness are more physically ill. They also have a higher risk of cognitive deficits. They may have social problems and functioning difficulties related to symptoms, related to a loss of their support system over the years. They may be at risk for community living deficits. We'll be talking about programs next week, such as HOPES and CBSST, that really address, and when I talk about community living deficits, I'm talking about things like transportation, making medical appointments, preparing meals, just sort of being able to live independent. Can definitely be compromised for someone who's been living with a mental illness for a long time. And there's also a very high risk of tardive dyskinesia with conventional neuroleptics, things like antipsychotic medications, first generation Risperdal, et cetera. And for anyone who, I know we have some folks from aging and some folks from mental health who are in the webinar, there's a wonderful pictogram from Mental Health America that goes over the signs of tardive dyskinesia, and the symptoms are often around the mouth or face or eye tics. It's a movement disorder that becomes permanent related to taking psychiatric medications. And it can be pretty severe, and unfortunately, there's no known cure at this time, although there are medications that can help mitigate some of the impact. So let's hear from you at this point. We're going to have another chat box question here. In 2 or 3 words, could you identify what are your most common issues when working with older adults with serious mental illness. So if you could just take a few seconds and identify some of the issues that you see when you've worked with older adults with serious mental illness. Well, thank you. I see a lot of ideas here. I really appreciate the input, and I see a lot of supports. The word supports coming up. Problems with memory, some housing, self-stigma is an issue that I see you have seen as well. Housing, income, being open to rehabilitation, having that belief that people can get better. I think recovery is a really important concept for us to consider. And we'll be talking a little bit about recovery at the end of this webinar, and also we'll talk about some recovery-based programming next week. All right, well, thank you very much for participating in that chat. I could see we've got a lot of really educated and important people who really addressed the problems of this population, which are very comprehensive. So we're going to move on now. Thank you for sharing some of your experiences. So now that you have some information on the unique issues and the common features of older adults and your own knowledge about the lack of resources, basically, let's look at some of the trends. We know that our population in general is aging, so there's an estimation that by 2030, our aging population will be 20% of the total population in the US, and that's according to the CDC. So we're definitely getting older as a community. When we look at the types of mental illnesses among adults, and this data comes from SAMHSA via the National Institute of Mental Health, they report that about 15% of people 50 and over have some type of psychiatric disorder, but some estimates are higher. So the CDC estimates up to 20% of older adults experience some type of issue. When we look at the breakdown, this is kind of a complicated slide, but basically it's suggesting that the percentage is at the bottom of that 20%. So there are a lot of anxiety disorders in older adults, also depressive disorders, and OCD, schizophrenia, and bipolar. So I do want to sort of look at also some of the normal aging changes. You probably are very aware of this, but there's issues with hearing, vision, sense of touch, taste, and smell. So all of those things are naturally worsening a little bit as we age, or changing as we age. But some of those changes also may be related to psychotropic medication usage, such as vision changes or sense of touch. And hearing loss is a very important issue. If you're curious later, you can download the slides and check out what hearing loss actually sounds like, because I think it's important for us to know when we're interacting with people what that experience is like. Hearing loss is very common as we age. Up to half of people in the general population have hearing loss over the age of 75. We don't have a lot of statistics about what that looks like for people with SMI, but I'm assuming it would be very similar. Also, vision problems are quite common. I bring this up because cataracts are a very common occurrence in older adulthood, and yet when I've run groups in different settings with older people, and they can't read the materials I hand them, and they can't see the board, and I'm like, where are your glasses? Where are your hearing aids? All of these things can really impact when we try to engage people and develop relationships, and also for therapeutic programming. There are sort of normal changes in the body that occur over our lifespan, and some of these are normal changes, and some of them are worsened through medication. So for example, bones do become a little bit more brittle as we age, but for people who take lithium, for example, those bones might become more brittle, and they may be at greater risk for more serious hip fractures, etc. Teeth and mouth changes. So There can be a higher likelihood of oral health disease. And for people who have serious mental illness, they take a lot of psychotropic medications, which cause dry mouth, which also causes cavities. And they may have spent a lifetime not getting great oral health care. I don't know what it's like in other parts of the country, but here in New Jersey, it's very difficult to find a dentist who accepts Medicaid. So people aren't necessarily getting the dental treatment that they should. Digestive changes are very common. And I know that this is sort of an awkward topic. However, constipation and stomach problems are very common as we get older, and that's actually compounded and made worse by a lot of psychotropic medications actually can cause constipation, and that can become so serious in the hospitals. A psychiatric hospital that I consult at, I've seen several times people hospitalized and actually die from infections related to severe constipation. So this is something that we really have to be aware of and be careful of when working with older adults. Also, sleep changes and cardiovascular. So cardiovascular issues are quite common, and they're the number one cause of death in people with schizophrenia and mood disorders. So we need to be aware of that. Reserve capacity. People may be a little more tired and have a little less energy for what we do. Sexuality is also impacted by aging in terms of our having lessened hormones, but the sexuality is also impacted by psychotropic medications. So it's important to be aware that some of these impacts can be even stronger in older adults with serious mental illness because they're facing both issues. I do want to share some good news. I want to be the good news bringer, and that is that dementia is not a normal part of aging. I know that many of us know that, but it's an important reminder that dementia is actually a group of symptoms caused by disorders that affect the brain. The most common is Alzheimer's, and certainly people with mental illness do develop Alzheimer's, but for the most part, there's no strong link between mental illness and Alzheimer's. There is a link, however, between brain trauma and brain injury and Down syndrome and dementia. So those are linked. Depression also is not a normal part of aging. I think that that's sort of a stereotype in our culture that we think that aging is depressing. I know my students often tell me how depressed they are at the thought of aging, and I tell them, well, wait until you get a little bit older and then you might not find it quite so depressing. However, it is often that people with schizophrenia do experience depressive symptoms. So we do have to be on the lookout for that. Yes. There are also some normal changes in thinking. There is some normal cognitive changes over time, things like word finding difficulty or response time. And those age-related changes are really different across the individual and across the cognitive domain. There's some evidence that education can be protective, that, also I always tell people that I work with that if you walk, there's a lot of evidence that walking and physical activity is protective for your brain, and you can actually improve your thinking and focus and concentration for people with mental illness and without mental illness, and at risk for dementia and not at risk for dementia. So take a walk is what I always end with in some of my groups. Dual diagnosis medical conditions. We know that there are a lot of these issues. There are more physical health problems, as we mentioned. Up to 2/3 of older adults with mental illness have multiple conditions. Up to 50%, have medical conditions that may be missed. And the health conditions are linked to medication noncompliance or adherence. And if you think about it, it makes perfect sense. If an older adult is taking 5 psychiatric medications and 5 physical health medications, and some have to be on empty stomachs, some need to be in the morning, some in the evening, the best pill box is not always helpful in addressing these very complicated medication regimes. And cardiovascular disease is also a problem. All right, other common health disorders. One thing we see, anyone who works with serious mental illness, they do see a lot of diabetes. And we know that the research tells us that there's a link between schizophrenia and impaired glucose tolerance. Also, a lot of the second generation medications cause weight gain, and that may also lead to diabetes. And diabetes is linked also to changes in psychiatric conditions. So respiratory disorders are also incredibly common, like COPD, which is linked to smoking. Respiratory disorders are the most common reason that people with mental illness are hospitalized in the medical hospital. Also, pneumonia is quite common in this population. Immune disorders such as HIV, hepatitis C are also fairly common, and arthritis, another type of immune disorder. Cancers are common, and hyponatremia, which is low sodium in the blood, basically, and that can be caused by hormone imbalances. It can also be caused by drinking too much, which is called polydipsia, and that may be a challenge for older adults with serious mental illness because a lot of medications can cause dry mouth. So people may be seeking more water, and then their electrolyte balance is off and can cause very sudden illness. So let's hear from you now. We've got a little chat box question. Are there other health problems that you have seen in working with older adults with serious mental illness? And we're going to get our chat box up here. Thyroid issues. And these are statistics about older adults in both in the community and in the hospital. I've combined them. Strokes, obesity, UTIs, chronic pain, circulatory issues, sleep apnea, that's a big one. Dental issues, skin problems. Yeah, skin problems are very common in community residing older adults with a mental illness. And addiction issues, I think that's really going to be something that's up and coming. We don't have a lot of data about that, but the statistics are ramping up, and we're going to talk a little bit more about that. Podiatry, definitely significant issues with podiatry. I will not forget, I was on a psychiatric hospital unit, and someone walked out and they had blood in their shoe, and we were like, what's going on with you? And the person was like, didn't even notice that something was going on with their foot. And I thought, oh my goodness. But I've also seen that in the community as well. And chronic pain and gait issues, I think those are really, really important points. A lot of sort of stiff muscles and gait problems definitely leads to fall. Okay, so let's close the chat. Thank you, everyone, very much for responding. I appreciate it. There's a lot of challenges that people experience living with serious mental illness as they age. And I just want to remind us that I have seen this, and I imagine you all have seen this often in younger adults. So we did a little project in the community with middle-aged older adults, middle-aged adults, I guess I would say the age range was like 18 to 60, but I found 45-year-olds and 50-year-olds who were unable to get up off the floor and had mobility problems that looked very similar to 65, 70, 75. So we're seeing, if you're working with older adults, or if you're working with people with mental illness who've been in the system a long time and are in their 50s, you're probably seeing some of these health problems that are more common in older adults. And many of these health disorders are linked to depression and anxiety. One of the big ones is respiratory issues. So for people with asthma or COPD, that is definitely linked to anxiety symptoms, or any kind of major chronic health condition is definitely linked to anxiety. There's a wonderful chart. I got this from the SAMHSA Integrated Care for Older Adults report. The references at the end of this slide set, but they have a great table, and I've excerpted some of it. One of the primary issues of people is urinary tract infections, and that sounds kind of like an odd thing that would be problematic for people, but it really is. It is something that is recurrent, and the symptoms may be different in that I've worked with older adults who've never even experienced pain. However, the confusion began literally within a day. So the difference, and many of you probably know this, but so for delirium, it could be the person is fine in the morning, and by evening, they don't know their name or where they are or what's happening, and they're very ill. And if you see someone, or someone has that experience, they should immediately seek medical attention, because that could be a UTI, it could be a stroke, could be a host of other health problems. But UTIs are extremely common, and the difference between delirium and dementia, we'll talk a little bit more about that in a minute. Other people have mentioned that thyroid disease is a problem, and that does occur quite often in people with serious mental illness. Also, alcohol and prescription drug misuse, and I would also say street drug misuse, can cause issues with cognition, delirium, and dementia. I know that someone that I had worked with who was an older adult sort of disappeared for a while and had a history of substance use, and he sort of showed up again, and he was just experienced great delirium and was quite confused, and we suspected that he had started using substances again and was really not well for a few weeks. It took a while to recover. So people who've had a history of substance use may think, and who have been clean for a while, may think that they can go back to their normal level of usage, and when they do, it really impacts them quite significantly because the changes can occur in the kidney and liver and processing of drugs and medications. There are a lot of challenges in medical care. There's a term called diagnostic overshadowing, and that means that the healthcare provider might look at the psychiatric diagnosis or medications and determine that a person's physical health or concern may be related to their psychiatric symptoms. And I've seen that, and I imagine many of us here have seen that as well. That person has schizophrenia, they're taking Risperdal, they probably won't understand anything that I'm saying, and by the way, their back pain is probably related to their symptoms of schizophrenia, which can lead to under or misdiagnosis of physical health conditions, and does lead to that. There's also the issue of polypharmacy, so people are taking multiple kinds of medications that may interact and cause significant health problems. Also, psychotropic prescribing practices. So when people are going in and out of the hospitals, they're often prescribe, leave with a certain regimen of medications, and then the new setting may not want to have that level of medication, and they change the medications, and then the person is at risk for relapse and going back to the hospital. There are also cognitive challenges, focus, concentration, executive processing difficulties that mean that it's maybe harder for an older adult with mental illness to follow up with medical appointments and the care that they need. There are also system issues such as silos of psychiatry and medicine. So there are more and more integrated care programs, which is wonderful. I know we have some here in New Jersey and in the region as well. And SAMHSA has been giving some wonderful advice on how to integrate services. But those, I think, are still, it's hard to access those services. And I don't know that they're as widespread as they could be. So I'm hoping that's the future of our treatment. There's also issues with reimbursement rates. So for example, if someone has Medicare only, they don't have Medicaid, it's very hard to find a psychiatrist who will accept the Medicare payment in our area at any rate. And it can also be difficult at times to find a psychiatrist who accepts Medicaid. There may be a long waiting list, and then a person may not receive the treatment that they need. So there are some additional considerations. For example, trauma. A lot of people with serious mental illness have experienced some level of trauma, and there are some literature reports that suggest that severe childhood sexual abuse is associated with medical illness burden and worse physical functioning. And other types of trauma impact the sensation of pain, and pain can be harder to treat in this population. Also, there is issues of stigma. So healthcare providers are not always very delighted to work with older adults or work with people with mental illness or work with older adults who have mental illness. And there's a lot of evidence in the SMI literature that people don't always receive the tests, assessments that they need from healthcare providers because of the stigma on the providers. And sometimes providers don't even believe that people can make the changes they need to improve. Also, diversity is an area that we have to consider. For example, culture. Culture is a very important aspect of who we are, how we age, and how we perceive health and aging. It also includes our language, our understanding of family, our understanding of what is good health, where our supports are. It can also include multi-generational households and the changing roles and family dynamics that occur as a person ages. There's also diversity in cohort of older adulthood. So we've been talking about this premature aging in our people with serious mental illness. So for someone who's in their 40s who may be having premature aging effects, that might be quite shocking, and a person may not be sort of ready to or understand what this aging process looks like. If we think about mental health, on the other hand, older adults may have a completely different perspective on getting access to mental health treatment as compared to, let's say someone who's 65, someone who's 55, 45, 35, and who's a baby. All of those people will have different experiences in popular culture, in our society, and in terms of accessing healthcare and mental health care. The other aspect to diversity that we do need to be aware of in the older adult community is the LGBTQ community is at very high risk for untreated health and mental health issues due to lack of trust and stigmatizing attitudes of healthcare providers at times. So we do need to be very aware of who we're actually working with, which I assume that we're all very good clinicians and we're asking people about who they are and how they are connected and what their family or who their family of choice is. I wanted to come back to delirium for a moment because it is such an important topic when we're talking about people who are aging and on a lot of medications. And that's really this sudden severe confusion. It's a rapid change in brain functioning, and it can occur with physical or mental illness, and it's usually temporary and reversible. And that's compared to dementia, which can be progressive and persistent functional deterioration. So the process of dementia can occur over years. And some of the causes of delirium are alcohol and drug withdrawal, drug abuse, electrolyte issues, and infections and surgery. So there are a lot of risks for delirium that people with mental illness experience. So we do have to be on the lookout for that and not assume it's sort of a normal process of aging. Some of the other considerations that we have to be aware of is substance misuse. And you all have already brought up this issue, which is wonderful, that we need to be aware that pain medications, the opioid crisis is targeting older adults just like the rest of the nation. And for people who may have used substances earlier in their adulthood, it may have just a much higher risk as people get older. And grief is an area that we also need to be aware of, that people with mental illness may experience grief as they age, just like everyone else. But I don't know how well we are doing in addressing that in terms of our outpatient and inpatient settings. Also, death and dying services. So if people are prematurely at risk for dying, we should be sort of having some open conversations about health risks and sort of helping people transition. And I'm not aware of a lot of interventions or research that's done on this topic. What I do know is there's been some research done to look at capacity for people who are having terminal diagnoses, and whether or not people with mental illness who are older are able to make the determinations that they need. And of course, that's a common issue in in people without mental illness as well. It's just sort of that capacity. And culture, of course, being very aware of who the person is, what they bring with them when they come to you, and what their strengths are and what their community can offer to them. Also, dementia. So just like everyone else, people with serious mental illness are at risk for dementia. And falls, as I mentioned earlier, so gait problems is what's called sometimes ataxia, some related to medication. People get very stiff and have difficulty walking, and also sedentary behavior, things like that. So the risk for falls is very, very high in this group. So the connection of mind and body, some health problems may precipitate or exacerbate psychiatric symptoms. There's this sort of link between health and mental health. The number of medical conditions correlate with psychotic symptoms and depression. And so we know there's just this back and forth between mind and body. So we always need to be sensitive and aware of that when we're working with older adults. So let's take a minute to hear from you. We've got a question that I'd like for you to answer in the poll. I'm going to put that poll up for you. And how do psychiatric symptoms change with age? We'll give a few seconds to let people finish answering the poll. All right. So I see we're kind of neck and neck. If it was a race, it would be sort of tied almost between worsen and both improve and worsen. So we're going to close the poll in a few seconds. So if you want to vote, be sure and get your vote in now. Vote early and often, as they say. All right, so we're going to end the poll. And so we end up with both improve and worsen, and absolutely, they actually do both improve and worsen. So, and for those of you who thought they worsened, for some people, they may actually worsen. But in the literature review that I've done, it's good news, bad news. So the bad news is that negative symptoms may worsen, and negative symptoms are those symptoms that allow people to experience pleasure, feel motivated, feel connected to their community. So those are negative symptoms, and negative symptoms definitely worsen for people with schizophrenia. And when we think about negative symptoms, it actually looks a lot like depression, right? So it's withdrawal, it's not being able to feel pleasure, it's sort of all the joy is a little bit sucked out. And so that can be challenging to know if it's depression or negative symptoms. Also, positive symptoms improve, and those positive symptoms, they're not good things. They're actually things like hearing voices, seeing things that aren't there, psychotic breaks, etc. And those actually do improve with age for people with schizophrenia and also for many people with bipolar disorder. However, long-term hospitalization often leads to a worsening cognitive abilities. So thinking, processing is not improved for people who have long-term hospitalization. There's often worsened attention and executive functioning, making decisions, step-by-step kinds of things. And there was a really interesting study that kind of highlighted the difference between people who've had schizophrenia for a long time versus dementia, early stage dementia. And they found that older adults with schizophrenia actually had more significant executive functioning and attention problems than people with dementia. And what people with schizophrenia did have, however, is the ability to remember over short-term memory was improved. And I think about that a lot because it's important that we know that people with schizophrenia basically have significant problems, but they don't have dementia. These are two different illnesses. And then sometimes people with schizophrenia develop dementia as they age as well. So it's very complicated clinically. And then the psychiatric medications and aging, there's a significantly higher risk of side effects and toxic levels of medications at a lower dosage related to functioning. And that can be related to kidney and liver sort of slowing down a little bit and processing medications differently. There are also significant central nervous system effects like sedation, extrapyramidal symptoms, which is sort of the tremors and the small movements, and also tardive dyskinesia. And there could be, there's some suggestion in nursing homes that antipsychotic medications may reduce the lifespan in older people. So I think more needs to be done in that area for us to understand it, but we need to be aware of the medication risk for people. Anxiety is very common in older adulthood, and that can link to a lot of other issues related to health and mobility and attention difficulties. Also, this pain perception for anxiety also includes it. So it may mean that people who are anxious need more pain medications. And then we do have to talk about suicide, that there is a increased risk of suicide. So the suicide rates for males and females in 2016, I'm just curious, we're not going to do a poll here, but if you ask yourself what gender and age group is at the highest risk, I think this is a pretty savvy audience. I suspect you're going to know the answer to this, but it is a surprise for a lot of, I teach a class in aging and rehabilitation, and my students are always shocked. We've got more men who are at risk of suicide. And also, if you look from the data from 2016, is that 32.3 out of 100,000 completed suicides, and that is the highest rate. In 2017, the data showed actually that the age group of 45 to 54 had the highest risk of suicide, followed by the 65 and over. So you can see that suicide risk is really very high in older adults, and it's probably very high in older adults with mental illness because they have a lot of the risks, and the risks for suicide in older people include depression, prior attempts, comorbid health conditions, social isolation, impulsivity, substance use, and recent losses. So I'd like to turn to something a little more positive now and think about the strengths of people with mental illness who are aging. There is definitely a clearer sense of self. There's some work that's being done about recovery models and what older adults with mental illness are saying about their lives, and they're saying things like they have established coping strategies, that there's some argument that people who are older with schizophrenia or any kind of mental illness, serious mental illness, are survivors, because if they have lived to be 50, 60, 70, they are unique in many ways because of the risk for early mortality. There's also some resilience in managing both health and mental health conditions. The decrease in positive symptoms means that people can have a better connection to their family and community. There's also an interest in achieving recovery and desire for improved physical well-being. So those are all things that we need to be aware of, that the literature tells us, and I'm sure that your experiences in working with older adults, you would be able to identify the strengths of the people that you work with as well. There's a wonderful video that I show in my class. It's from the UK, and it's interviewing a bunch of British older adults who've lived with mental illness, and the end scene is wonderful, and they're sort of displaying their strengths. They're talking about their commitment to dancing, their connection to friends. It's incredibly powerful, and I think that you probably have seen all of these things in the people that you work with as well. So let's hear from you. We're going to have a chat box question now. What are some strengths that you have witnessed in older adults living with mental illness? So in your own work, do we? I'm seeing a lot of sense of humor, which is wonderful, and resilience, self-determination, survival skills, and tenacity. Yeah, this is a group that is pretty remarkable, and able to really pretty remarkable. And also helping others. The newest area of services, we'll talk more about this next time, is older adult peers, helping other peers. And I think the willingness and interest in helping others is wonderful. And the positive attitude, yeah. All right. Well, thank you so much for sharing your strengths that you've observed, because that makes us more effective in our work with older adults. I also did want to talk a little bit more about recovery in older adults, because we are from the Department of Psychiatric Rehabilitation, which is about recovery from mental illness, and that means sort of living well despite having an illness, and reclaiming life's purpose, meaning, and goals. And some interviews with older adults have shown that the recovery, and you've identified a lot of the strengths and how recovery happens, is that people are feeling pretty satisfied with their life despite the losses that they may have experienced. They may also value very much the sense of control over one's life decisions, and that's comparable to older adults without mental illness. It's a parallel process, really, is this idea as we age is wanting to be as independent as possible. Also engaging in meaningful activities wherever a person is and whatever their life situation, to have important things that happen each day are very powerful. And also living in a setting that promotes optimal functioning and independence. So in summary, this is quite quite a growing population, and there have been a lot of unique challenges related to medication and health concerns. The psychiatric symptoms do change and fluctuate over time, and they are influenced by health. This bi-directional relationship between health and mental health is really pronounced in this population. And finally, we know that older adults are invested in recovery and invested in feeling better and living a better life, which we have to keep in mind. So I think we have plenty of time for some questions. Oh, sorry about that.
Yeah, so I'm going to open up the questions. So you should have a Q&A box at the bottom of your screen. If you want to type in questions for Dr. Zechner there, and I will pose some questions to her. So I'm gonna start with a question that I have as you guys are putting together some questions of your own. So I was wondering, Dr. Zechner, if you could clarify a couple of things, or actually sort of boil down some takeaway messages. It sounded to me like there are really 3 or 4 populations here. So there are older adults who don't have mental illness, people who didn't never have a mental illness and are just aging. Mm-hmm. And then we have older adults who didn't have a mental illness sort of during their earlier life, but have developed a mental illness now in their older adult years. Mm-hmm. And I think you said that depression and anxiety are common at that time. And then there's people who had a mental illness sort of throughout their life, diagnosed at an earlier age, a more sort of typical onset age, who are now in their older adult years. And I'm just wondering if you could, again, sort of boil down for us some of the critical differences you see between really that second and third group, people who didn't have a mental illness but now have developed one in their older years, and folks who had a mental illness throughout their life and are now in their older years. Are there sort of critical things that we should keep in the front of our minds?
Well, I think that the issue of stigma is a pretty pronounced one. So for someone who's lived with a serious mental illness for 20 or 30 or 40 years, they may have experienced a lot of losses, a lot of stigma as a result of their diagnosis, and sort of a sense of, I don't want to speak for the population, but I think that people don't have the social networks or the social supports, whereas someone who develops a depression and anxiety in later life may have a robust family, they may have had a full work history, they may have social networks that are much more solid than someone who has had mental illness all their life. That's a generalization, because they're always, different people, but that's how I would categorize it.
We also had a question about, let's see here. Sorry, I'm sorting through the questions here. An early question about socialization and the lack of socialization with older adults.
I guess I'm not sure exactly what that question means. Is that older adults are not socializing, or is it that we as a culture are not socializing with older people? I'm a little confused. I'm sorry.
Well, I guess, what do you think about the role of socialization or lack thereof among older adults?
Well, social skills are really, really important. And for people who live with serious mental illness, social skills training is really, really valuable and important. In fact, some of the promising and evidence-based practices that we'll talk about next week target social skills training for people with mental illness in terms of, basic social skills. If you think about, there's a wonderful the social skills training workbook by Belak, Musser et al. That has a wonderful overview of that type of thing.
Excellent. So another question that's been posed is, maybe gets a little bit at my first question for you, but that for people with co-occurring mental illness and chronic physical health conditions, the question is, for people who have schizophrenia and bipolar disorder, maybe compared to people with depression and anxiety, do you think that there are different management approaches that need to be considered in terms of providing support and care for those individuals? And in essence, do we need to make a distinction between the serious mental illnesses and mental illness in terms of determining what might be effective treatment?
That's a really great question, and I'm not sure that I have a clear answer to that because I have worked in the mental health field. I have worked in nursing homes and providing case management to older adults without serious mental illness, and there is some overlap, particularly for people who have our older adult population who are at high risk of poor social determinants of health. So they may have, live in poverty, they may have food insecurity, housing insecurity. Some of those issues are very similar. But the challenge is that there aren't a lot of interventions, or there's not a lot of understanding even about how these populations differ. There are some differentiations in the intervention approach because there's this assumption that people living with mental illness for many, many years may have greater cognitive challenges. They may have access to different levels of resources. They may have skills deficits in different ways than people who are diagnosed with mental illness later in life.
Thank you. Okay, we have another question here about, you had indicated and talked a little bit about people with serious mental illnesses aging early. And so the question is, why would we categorize people with serious mental illness as older adults at 45 or earlier than people without mental illness? Can you talk to us a little bit more about what the evidence is or what leads us to make that determination?
Yeah, that's a really, really good question. I was really taken by, there's an article by Dilip Just from USC who talks about accelerated aging in people with schizophrenia, and particularly related to the cognitive realm and the biological realm. So the issue is that for people who've been taking medications for many years and been in the public mental health system, they're much more likely to have health conditions and chronic health conditions that are more similar to older adulthood than people who don't have a mental illness. So they're experiencing health conditions, physical changes, physical mobility difficulties, and overall thinking problems at times. And this is not across the board, but there's a certain, I guess, like a subset of a group of people who maybe their symptoms are not well managed, or they're taking multiple medications over a long period of time, that their presentation is much more similar to an older adult than a younger adult. So that's where I'm basing it. And as the definition of 45, I had a lot of problems with it because I slightly resemble that age range. And I had a lot of problems with that, but we've just conducted a systematic literature review where we looked at over 2,000 articles and looked at older adulthood and wellness in people with serious mental illness. And we started out defining older adulthood is 65. We had a lot of difficulty finding anything. Then we lowered it to 55. We found some, but still we discovered that a lot of people who are publishing in this population, Dr. Stephen Bartels, for example, is someone who publishes a lot in this area, and Dr. Sarah Pratt, they're defining older adulthood in people with serious mental illness as 45. Additionally, we need to remember that people are dying earlier. So the age, if we think about the average age, life expectancy in people without mental illness is 85. And we think that people with mental illness may be at risk for premature mortality of up to 30 years. That would mean that they might be at risk as early as 55 of people passing away. And of course, anecdotally, I've known a lot of people who attend mental health, community mental health centers, and people in hospitals who are dying in their 40s and early 50s.
Okay, thank you. We have quite a few really great questions here, so I'm trying to work my way through some of them. So there's a question, follow-up about dementia and delirium. Can you talk a little bit more about why you categorize these as mental illnesses, and maybe a little bit more about them, about what they are, and how you would define.
Okay, so in the aging world, dementia and delirium are considered mental illnesses. And so when you go to nursing homes, or when you go to assisted living facilities, or when you are working community senior centers or areas agency on aging, they're thinking about mental illness, and they're thinking, they may not always use the word mental illness, they may use behavioral disorders or behavioral issues, and often that's related to dementia and delirium. So, and those are codes in the DSM. So that's why they're considered mental illnesses. Dementia is a cluster, it's basically a cluster of symptoms about memory loss and a cognitive decline that occur over time. And it's not just memory loss, there are changes in visual perception, there are literal changes in the brain as a result of Alzheimer's. There's also other kinds of dementia. But typically dementia takes years to sort of run its course. I think the average life expectancy for someone who has a diagnosis of Alzheimer's is 7 years. Delirium, on the other hand, is related to a medical or psychiatric condition. So someone who has delirium wakes up in the morning and they may know exactly, I'm in Scotch Plains, New Jersey, my name is Michelle, and by the evening I might think that I am in my grandmother's house and my little dog from childhood is sitting there with me and I'm talking to that dog. Of course, that could be related to delirium and infection. It could also be a psychiatric symptom if someone has a history of long-term psychiatric conditions.
Thank you. And just to clarify, so some of the ways to make that distinction between delirium and a psychotic episode triggered by a mental illness is the rapidness of onset, and also the screening for potential medical.
Yes.
Mm-hmm. So there's another question about lack of motivation among older adults with mental illnesses, and challenges that people see in working with those folks, particularly if they have depression. Can you speak to that at all? And I don't know if that's something that's going to come up in next week's talk, if any interventions have been developed around motivation for older adults with serious mental illness.
Yes, we are going to talk about that next week with some programming, and I think that is a problem. It is a really significant problem, and I've run groups in the psychiatric hospitals. I've run illness management and recovery groups in state psychiatric facilities with older adults, and I know very well how challenging it is to engage people and get people excited and interested. And there are some strategies you can use. I think goal setting is a very interesting strategy. It does help with motivation, but it takes more time and maybe, I would argue, maybe a little bit more of a directive approach to help people actually think about goals and explore the areas that they're interested in learning more about, and kind of get over that self-stigma. I mean, I remember people in other groups telling me, I'm an old dog, you can't teach me new tricks. And then we had sort of a really lively group discussion about how, is that true? Is it true that people can't learn new things as they get older? And we had a great discussion. So I think that part of that lack of motivation, it is always going to be a challenge, but it's being patient, working with the person and trying to identify what has meaning and purpose for them, what would make them more invested in doing something. And that's also a common therapy for depression called activation therapy, where it's sort of like you're asking the person to sort of push themselves, but that requires a little bit of energy. And sometimes people who've had mental illness a long time may not even have that energy for that.
Thank you. Another interesting question, and again, you may be getting into this next week when you talk about services, but what do you see as some of the program and service delivery implications for the growing aging population of people with serious mental illness?
You all have some wonderful questions, by the way. I'm very impressed. I think that some of the implication is that we need to be a little more sophisticated in our understanding. I think you all are bringing up these questions, and these are really good questions, and questions I think about and struggle with. And the truth is, there's just not a lot of literature out there. I have been teaching an undergraduate class since 2010 in this area, and every year I'm scouring the literature, trying to think about rehabilitation and programming and services that we need to be thinking about it. I'm really kind of at a loss because there have been calls to action since 1999 to address this population. That's 10 years, and I'm not sure that we've gotten much farther along. We do have identified some best practices. There have been a couple randomly controlled trials. So I think we need to do a better job in identifying the kinds of programs that would be helpful. Also, we need to hear from this population. I'm not even sure we have a very good sense of who these folks are and how we're going to define them. As I mentioned, we're talking about older adulthood starting at age 45, which is ridiculously early, but we need to understand from people with mental illness what their perspectives are as well. And we also need to have a better sense of the data in terms of how many people of this population are actually utilizing mental health services, what are, the kinds of costs, expenditures that are involved, so that we can target our services, I think, a little bit better and be more sophisticated in general clinically.
So there's some questions here trying to get at that about how do we train and prepare the workforce, particularly, well, I guess I see it on both sides, right? Preparing the behavioral health workforce to be better able to meet the needs of people as they age. And then in the services that are typically for older adults, nursing home, long-term care facilities, how to prepare them to better work with people who have mental illnesses who may be in their care. Are there interventions or training, or I guess, can you speak to, if you know of any, formalized training or education programs that really help to get at that?
I'm not very familiar with that area, and I would say that if people are interested in that area, they should really check out the Institute on Medicine's workforce development report. I think it's called In Whose Hands. It's in the reference section that lists the different models. I do know that a lot of nursing homes have partnerships, and there are different models of training nursing home staff and assisted living staff and other kinds of aging staff on how to handle, like, kind of mental health first aid for older adults, and how to address dementia and delirium. I am not familiar with too many. I'm actually not familiar with any programs. We did a paper recently on this topic of some training we did at a state psychiatric hospital for their staff about aging. And at that time, I did a literature review, and I couldn't really find too much out there. And I'm sure there are some examples, but I don't know that they're very well publicized or widespread.
Thank you. There was a question about the dignity of risk, and also some questions about safety. And to me, those two pieces often end up coming up sort of in the same conversation, right? The importance of the dignity of risk for people, older people, people with mental illnesses who are older, and how to balance that with safety concerns. Just wondering if you could share any thoughts you have about the importance of dignity of risk for this population, and also what considerations may need to be taken into account, if there are any that are unique.
Well, I think dignity of risk, for any older adult, is really, really important because it's a sense of self, it's empowerment, self-efficacy. Also, for people who've lived with mental illness, it's really inherent in, it's really important to the goals and values and principles of psych rehab and recovery to honor someone's choices, to involve them in their treatment, to allow people, as we call it, to fail forward, where you allow people to sort of make small trials, and sometimes they don't always succeed, and that's sometimes a learning opportunity. However, this, balances out with safety concerns. And if, I know that mental health providers often have to make that sort of call. I know that housing providers in particular may be struggling with this issue a lot. And I've been talking to some housing providers in New Jersey, and they want to have this conversation. So I'm going to be thinking a little bit more about this issue. Because we have, unfortunately, if someone's in our system of care, we do have the responsibility to make sure that they're safe, but at what cost? Other issues that I think likely will come up is refusal of medical treatment is a big one. I know that one of the housing providers was talking to me at great length about a woman who was diagnosed with breast cancer and decided, I think she was in 61 or 62, and she'd been in the house for several years, and she was emphatic that she didn't want to have treatment. And, we had many conversations, and I know that the group home had to have conversations with a psychiatrist about her capacity to make that decision. However, it's also preference. I mean, even if someone doesn't have the capacity to make difficult health decisions for themselves, they should definitely, their preferences need to be taken into account. And if someone is not interested and doesn't want to go through difficult treatments or surgeries, they should have that. I think they should have that right. And there should be a lot of discussion and decision making with the person, their team, their supporters, their family, whoever else is involved to try to negotiate these hard decisions.
So additionally, I'm wondering, I'm sorry, an additional question. So you talked a little bit about social skills training and the role of social skills training potentially in supporting social engagement and interaction for older adults with mental illness. And there are some social skills training materials developed, and there was a request to send out a link to that resource, which we can certainly do. But I'm wondering if you see, there was a question about potential differences in social skills training for older adults with mental illnesses compared to younger adults. Are there any, do you think there are any particular things that might be critically relevant for older adults? So I'm thinking, for example, not that this doesn't apply to younger adults, but maybe more important for older adults is negotiating with healthcare providers or advocating for oneself with healthcare providers, that might be an interaction skill that would be critically important. Does anything else come to mind? I know we're throwing a lot of questions here at you that you were not given ahead of time. So on the fly.
Yeah, that's a really interesting question. I would say that that the healthcare navigation has, and that has actually been studied by Dr. Bartels. I know there's at least one article where he explored social skills training in how to ask questions of your doctor, things like that. I think also just knowing or having some experience in the older, the aging realm, I would think that for every time I come up with something, I'm like, these are very parallel. I'm thinking like, well, for older adulthood, it might be things like, how to say no to financial requests. But I think that that's relevant for people of all age. So I'm not sure. I'd have to think about that, honestly. Yeah. I think that health, I think also,
well, it sounds like a lot of the skills are comparable.
There are a lot of comparable skills, yeah.
And it may be because of the some of the challenges that both people with serious mental illnesses and older adults who may not always feel that they have power or control in a situation, that developing those skills to have a voice and sort of own their power is important regardless of age.
Right. It may, I think cognitively there may be some differences in how you approach the social skills training process itself. So it may take a little more time for an older person, and you may need to use different techniques but I'm not sure that we've, the literature isn't that sophisticated as far as, I could be wrong. I don't believe that we're talking about that.
Mm-hmm. Okay, let's see if there's just one or two more here. I don't know if you know the answer to this, but there's a question about challenges for those in more rural areas. Do you know, I don't know that anything in the literature exists explicitly on this among older adults with mental illnesses. I don't know if you've seen anything.
I haven't seen anything. I certainly, I haven't seen. I know that there are significant differences in the access in rural communities, and I think that this is kind of a specialized population. Even in New Jersey, when I send my students marching out to do site visits that serve older adults with serious mental illness, and we are very challenged. And I think we're fortunate. We have about 3 or 4 dedicated outpatient programs. We've got about 3 or 4 inpatient programs. So we're quite fortunate, but I know that access would be an issue. And I actually haven't seen very much at all in terms of rural, because transportation and access to care, I think, would be the biggest issues. But
so the last thing is that there have been some questions about the integration of care around physical health care and mental health care. We know this is a significant issue among people with mental illnesses generally, and SAMHSA and some others have done some good and important work and are currently funding multiple projects around evaluating primary and behavioral health care integration. Is that anything that you can speak to, or is that coming up in your talk next week?
I guess in terms of the integration of care, some of the models of care will be described next week in terms of the types of programs and how they approached it. So again, unfortunately, and it may not be helpful to the audience, but it's sort of how the services are offered, because I constantly question myself. If a service is an evidence-based practice for age-onset depression, has it been used in people who've had long-term mental illness? And often not. So I've developed sort of a 2-line approach to discuss the evidence-based practices for depression for the general population and later onset. And some of those models, like there's a model called PEARLS and integrated geriatric collaborative services. I'm just thinking, I lived in Pittsburgh for a while, and there was a thing called Benedum Geriatric Center. So there are these sort of health clinics that combine health and mental health services. So we'll be talking about some of those approaches. I'm not sure that I'm going to delve too deeply. I'm just going to give you some examples of what those programs look like. And
it sounds like that gets back again to that early question of those these different subpopulations, and maybe the need for some additional work around what practices have evidence for older adults who have sort of new, later age onset of mental illnesses, as opposed to people with serious mental illnesses who are now in their older adult years, and whether the evidence carries over, or whether it's a different group of people who need different interventions. And similarly, if the evidence-based practices for people with serious mental illnesses continue to be effective for people in their older age. So it sounds like there's a lot of important work left to do in this area. But next week, you are going to talk to us a little bit about what is known around those services and interventions. And I'm sure highlight those distinctions where there are areas where we're not sure about the effectiveness.
Right.
Excellent. Okay, well, we are going to bring this webinar to a close. Do want to thank everybody for their active participation. We really appreciate it. We encourage you to join us for part 2. Where Dr. Zechner will talk to us more, as we were just saying, about evidence-based and best practice recommendations and considerations around interventions and services for older adults with serious mental illnesses. It will be next Wednesday at the same time, 12 o'clock. And again, just to highlight that if people are interested in receiving certificates of completion for attending these webinars. You do need to be present at both this webinar and the second webinar. So please keep that in mind and join us again. In the presentation, the slides for this were sent out and have these resources that Dr. Zechner has provided for us. If you didn't receive a copy of the slides for some reason, please feel free to email us. Our email is let me get this right, Northeast Caribbean at MHTTC.org, I believe. Let me clarify that for you just so that I don't tell you the wrong thing. Okay, well, how about this? Let's do this. You can email me at ann.murphy@rutgers.edu. That one works for sure, and we will look forward to any additional comments or thoughts that you have. As I noted earlier, we will be conducting evaluations of this webinar. Those will be distributed following the second webinar next Wednesday. We will follow up with a link for you to provide us with your feedback. We are very interested in your input. And again, those surveys are also attached to our funding, so we greatly appreciate your willingness to complete them. So thank you, and we look forward to seeing you next week.